My dear friends, every breath counts. Therefore, count every breath. I think this is a very good message from me. Let us make Black India green. This is our social responsibility.
Today, among us, we have one of the most prolific, the most intelligent speakers of all of them, and that's none other than Dr. N.K. Subramanya. Listen to the most important updates in the field of pneumonia. Stay tuned. I'm Dr. Manjunath Sharma, and I'm a pediatrician and allergy specialist. This talk was given by Dr. N.K. Subramanya in Guwahati in the midterm Respicon.
Let me thank IAP Assam and my friends in Northeast for conducting this midterm Respicon as the past chairperson of the National Respiratory Chapter. And they need applause for two reasons. One, for this successful conference, and second, for making the unique cough module, which was the most popular module in IAP. I think Northeast requires a big round of applause for making such a nice module in our tenure, which ran successfully. And thank you very much for inviting us on updates on pneumonia. You may be wondering what is there in the update on pneumonia. I would just go through some of the areas. It's very difficult to cover entire pneumonia in 20 minutes. And therefore, let me focus on what we have got new in definition, severity, etiology, risk stratification, diagnosis and management. I don't think there is any pediatrician who is not managed pneumonia, who is not going to manage pneumonia in the audience. You have all got the experiences. Let me take that you have got the baseline understanding of management of pneumonia. I would just move on. Definitions. Is there a single definition for pneumonia? This was a problem for me. Whom you say yes pneumonia, no pneumonia. Are you understanding? Now I am coming to a next level where you will have some problems. Now, is pneumonia a disease? Is it defined as a disease or is it defined as a problem? I will tell you, the problem is we doctors, pediatricians and practitioners have defined it as a disease. We use stethoscope, pulse ox to assess. We use various references to justify. We listen to so many conferences, webinars, etc. to make a disease which includes signs, symptoms, history, investigations and make a syndromic diagnosis. That's what we are, correct now as far as pneumonia is concerned. And we always ask this question, which antibiotic to give, whether to give or not to give antibiotics, and how to give antibiotics. This is all the debates that have been going on for years, and I have summed up all your past conferences in this slide. And the issue is, when you look at pneumonia as a problem, this is the picture we get. Malnourished, overcrowding, and then the organizations will pitch in, like WHO, UNICEF. Now IAP is sandwiched between the two to take pneumonia as a disease because pediatricians are members, and to take it as a problem when it looks itself as a very advocate body for giving directions to the government and the authorities on management and reduction of the mortality. And so is Ministry of Health and Family Welfare and CDC. That is why there is a problem in definition. Whenever you try to define it as a problem, then disease definition gets compromised, and whenever you define it as a disease, XYZ, then the problems get submerged. Therefore, what's the way forward? What I did was I just Googled childhood pneumonia and I got more than 3 lakh. If you just Google now, you may get 4 lakhs also. Another 1 lakh must have been added. Just what is pneumonia? See, it is so surprising that there is no single, thing that you would get on net or in the literature. And I looked at the WHO website. This is directly from the website. You can see it has defined pneumonia as an acute respiratory infection, and there is a fear of death. It can cause death. So therefore, WHO is looking at it as a problem. Are you getting my point? They are not trying to define it as a disease. Look at UNICEF. They say somebody will die every 43 seconds. What does that mean? Again, it's looking at it as a problem. If you look at IMNCI, more than defining, it is trying to put the children in different zones of severity, yellow, green, red, you are already up, etc. You understand my point? So therefore, the whole issue is not about defining the gray zone. Anywhere from normal to death, you are given different colors. I looked at the standard guidelines of IAP, which also took this as, they just left everything and took community-acquired pneumonia as the solid baseline. And the authors are here only. I think Rashmi Ranjan Das and couple of them, we had lot of conversations on phone when this module was also made. And then this went on to become a kind of a document. I have my own, from the respiratory chapter when I was secretary and president, we made 550 slides on pneumonia module. We have also made a document. I think Dr. Neelamohan was my colleague, we presented also. It was to be again represented with some evidences. And then, even here, even in my leadership, we have not answered correctly what is pneumonia. I am criticizing my own, which was around 4 years back. Now we'll move on further. What is pneumonia then? Is it that all pediatricians are looking at an elephant and describing what it is? For some, it is LRTI. Do you all agree? Now don't say no and don't cheat yourself. I want you to speak truth and only truth and nothing but truth. For some pediatricians, it is the infections that requires antibiotics. He just sees, अगर इसको antibiotic जरूरत है उसको pneumonia बुलाओ. For somebody, it starts as not URTI. गले के नीचे है तो उसको pneumonia बुलाओ. For someone, they teach it as bronchopneumonia. And some people call it as consolidation when they want to use the word either in pathology or radiological diagnosis of pneumonia. Is there an X-ray that would pick up anything like congestion? Very, very difficult. You understand it not either increased bronchoscopy markings, which is non-specific, doesn't qualify for antibiotics. So different phases of pneumonia captures differently in radiology, and only consolidation gets picked up well. Are we referring to pneumonitis also as pneumonia? Inflammations? I'm confusing you. I'm happy if I'm confused. At least people are all strongly recommending. Everybody raises their hands in the audience. Oh, I won't give antibiotics on Sunday, but Monday morning they will write antibiotics. For all the viral associated V's. So therefore, my dear friends, is there no viral pneumonia? I think today I have not updated you, I have confused you on pneumonia. If at least I have done this, I am very happy. But the answer is, the best working definition could be, just stick to the word community acquired pneumonia, because you have to give empirical antibiotics, and to give empirical antibiotics, you need to know from where the organism has come from. The point is very, very important. We are not giving antibiotics after culture. We are giving empirically, and therefore you need to know whether it's from the hospital or community. That much is enough for me. Is that fine? All of us are fine. Second is WHO, which says no pneumonia, pneumonia and severe pneumonia. What does that mean? Is it defining pneumonia or is it grading the severity? It's grading the severity. So the answer and the message number 1 says that you define pneumonia by community acquired pneumonia and grade the severity. Now, although I confused you, I gave you clarity at the end, little more confusion. There are lots of classifications that are used: simple pneumonia, complicated pneumonia, viral, bacterial, atypical, fungal. Every typical pediatrician has an atypical presentation of pneumonia in clinical practice, and every atypical pediatrician has some more atypical plus typical in his clinic practice. Immunocompromised, non-immunocompromised is difficult to measure in practice. Are we speaking of clinical or radiological classifications, infectious, non-infectious? Therefore, again, the better classification is community-acquired pneumonia and hospital-acquired pneumonia. I have oversimplified for all the students and the practitioners. Don't go for various classifications. A simple classification of community-acquired pneumonia and not a community-acquired pneumonia. And again, here classification, better to classify severe and non-severe pneumonia. Are we all done with the message number 1? There is a clarity out of confusions that we speak community-acquired pneumonia and define the severity. Are you all okay? Loudly okay? Okay, first point. Okay, next. Yes, severity. Sir, you have already talked about severity. Now, what more you are talking about severity? It's very important because the children are dying. Are the children dying from non-severe pneumonia or they are dying from severe pneumonia? They are dying from severe pneumonia. So when you are talking about mortality, you should talk about severe pneumonias. Please understand my point. Or the pneumonias which become severe. Rather than debating about some 2-year-old child with cough presented with this X-ray, I gave ceftriaxone. They are not going to die, please understand. In 2 days, they are going to get discharged. Most of them, be it on oral amoxicillin, etc. Therefore, my dear friends, when I use the word severity, there are only two things that pediatrician need to look at. One is severity and presence or absence of complication. Do you need great tests to do for this? You need an MRI for this? Just to see severity and look at complications, you don't need great investigation. Please understand, you have to look at evidence for hypoxia in the child. Any child which is becoming hypoxic is the one which is getting into a severity or getting into some complications, and hypoxia is monitored clinically in various ways. I look at the focus now. We shifted from all the symptoms to focusing on physiology, that is hypoxia, and hypoxia precedes all symptoms. First there is hypoxia and there is responsive tachypnea. First there is hypoxia and then there is chest recession. First there is hypoxia and then there is cyanosis. First there is hypoxia and then there is head bobbing. Are you getting my point? So hypoxia is important, and hypoxia can be captured much before it manifests clinically, and it should be done by all the pediatricians, and that is the crux of the matter. And I'm just playing with the words. Severity is a measure of hypoxia. Now, are you loving this? Did you understand? Basically, we are all coming to the point that let me measure the severity, and that's important to me. Why should I follow WHO? Is WHO guidelines is for the health workers? Answer is no, because WHO also measures severity. Further, hypoxia is a measure of mortality. My dear friends, therefore, you need to define pneumonia, community acquired or otherwise, for your sake as a clinician, and you have to measure the hypoxia because you want to prevent the deaths. And I think I gave you little bit of clarity, but let's see what happens when pneumonia do not respond or worsen. I said we look for severity and complications. Are the severity and complications unrelated to each other? They are related to each other. A pneumonia with complications will become severe, and a pneumonia which is severe could be the one which is having complications. Did you understand? How do we see? We just do some blood tests, CBC, CRP, neighboring house CRP, next door blood culture. All these things don't help you. Please understand my point. You have to assess clinically, look for red flags, and keep on monitoring the respiratory rate, and which we often don't do. And this is the most important point for assessment of severity. And my dear friends, if you want to look for complications, you have to go for imaging. And there will be full conference on all these importance of all these imagings, like a chest X-ray, role of an ultrasound. Ultrasound is the most important, and I think all of us should learn ultrasound. Now obstetricians are making money. Why not pediatricians should make money? I think I would appeal to Neelam Mohan to enable legally that every pediatrician should get license to do ultrasound, and legally we can't. And that's the point that IAP need to take it forward. Message number 2, when pneumonia doesn't respond, assess severity and look for complications, and this is very, very important message. And let me go on updates on etiology. What is the bug? If it is streptococcus, it will be toxic, lobar, localized. Staphylococcus, empyema, necrotizing, pneumococcal. If it is atypical, looks like viral, walking, diffuse lung involvement. And if it is viruses, follows URTI, bilateral, and it has prodromes, etc. All of you know this. We have been teaching this, differences between bacterial pneumonia, viral pneumonia, and mycoplasma pneumonia. For all of you who have understood or not understood atypical or mycoplasma pneumonia, let me tell you, mycoplasma in size is between a virus and a bacteria. It is smaller than a bacteria, bigger than or larger than a virus. Do you agree? And therefore, its clinical features are in between a viral infection and a bacterial infection. Very, very simple. It behaves the same way, and you need not have to by heart all the clinical features. Now, how does the etiology guides our treatment? If you have empyema, large effusion, add ceftriaxone. If it is MSSA, like necrotizing, we have to add cloxacillin. If it is MRSA, you have to add vancomycin. If you have immunocompromised host, newborn, etc., you have to add aminoglycosides. Then low-grade organisms means don't add metronidazole, but add clindamycin. So therefore, if you know the etiology, it will guide your treatment. So therefore, we should try to explore the etiology. That's very, very important. Even in severe pneumonias, etiologies remain the same. How do we know the bug then? Can I do tests? Can I do blood culture? Only 15% of the pneumonias will grow some organism. Can I do RT-PCR? Available somewhere, not available somewhere. And RT-PCR is not in the hands of every pediatrician. It is for more or less for outbreaks, intensive care situations. Some of them are very expensive battery of tests like BioFire, etc. So therefore, my dear friends, although it is specific nuclear test, it is very difficult to do in day-to-day practice. Very rarely some of the X-rays help us to pick up a miliary for TB or a pneumococcal for staphylococcus, give us some clues to the etiology. Then, how should I know the bug? My dear friends, bug is a simple guess by age. If it is less than 2 months, I will assume that there is gram negative. If it is between 2 months to 2 years, I will assume these organisms. Are you getting my point? More than 5 years, suddenly mycoplasma, don't say what is your age and then infect the lung. Did you understand my point? More than 5 years, why we get mycoplasma is because less than 5 years, other organisms will be more common. As and when you come to uncommon age group, then uncommon organisms will come in. Are you understanding the logic? So therefore, for empirical therapy, my dear friends, let me tell you, the bug is a function of age. Did you all understand this concept? And don't do investigation just because you want to know. Or the parents, I want to convince the parents. Weigh against benefits and costs. And if it's going to make a difference in your management, you should do. Message number 3, what is the organism? It's a nice guess as a function of age. Investigations are mainly supportive. They should not direct you too much, but they help in some special circumstances, which I have already told you, and the tables are there for you. Now let me go to 4th update, and I have only 2 more updates to make for you. This is most important. Anticipation and risk stratification, which is what the pediatricians want. Mother will ask, tomorrow kaisa rahega? And every mother who admits a child with pneumonia, guarantee dete ho kya? I don't know whether you are facing, at least everybody will squeeze my neck and ask me, will you give a guarantee? Do you all agree? So let's see, can we give guarantee? Now, non-resolution is possible if there is an underlying disease, congenital heart disease, malformations, pre-existing disease, or if there is immunodeficiency, malnutrition, environmental issues, etc. That means, here, even if you give the best drug, please remember these points. If you are treating a child with VSD with pneumonia, you should be careful. That's the point which I am coming to. You are giving empirical therapy in the ward, but you should be careful. Now, recurrence you anticipate. Don't wait for definition which all is available in the science telling that more than 3 pneumonias, I will start investigating. That means you tell the mother, have 2 more pneumonias and then I will come and investigate. You are getting my point. You can preemptively feel that yes, it is going to recur next. You have many cases. For example, a child with a neurological disease has an aspiration pneumonia. You know that it is going to aspirate next. Don't wait for something like, say, there should be minimum 2, 3 or 3, 4 episodes. So be it structural, foreign body, immunodeficiency, malnutrition, cystic fibrosis, primary ciliary dyskinesia. Even in the first episode, you must preemptively anticipate and do the risk stratification, and it is possible. Investigate directed by the history. Message number 4, investigation should not be a battery of tests. I'm going to wind up in 2 minutes. I have only one more message. You don't do a battery of tests. Investigation should be directed by a good history. Let me look at updates on diagnosis. All of you know this, I'll quickly browse through. You use fever, cough and fast breathing. They have high sensitivity and a high negative predictive value for diagnosis of pneumonia. That means if there is no fever, there is no pneumonia. But if there is fever, it may not be pneumonia. Are you getting my point? What I meant by that? These are non-specific. On the right side, you have specific, little specificity. Some of them are specific, but some of them are also late and they are less common, like chest pain, hypoxia, workup breathing. I know there is pneumonia. It doesn't require a pediatrician to tell pneumonia. Mother will tell there is pneumonia. You got my point? So we are caught in between specificity and sensitivity for diagnosis of pneumonia, and you have a combination of them. And when we teach the students about crackles, rales, crepitations, wheeze, rhonchi, diminished breath sounds, which we all write in our case sheets and in our OPD prescription, they don't have any good value likelihood ratio, sensitivity, specificity, all of them are poor. The point is, it's better to put a toss than to auscultate a patient. To this extent, I am showing you sensitivity, specificity. For want of time, I will share these slides later, but please note that these are all the issues related to pneumonia as far as clinical diagnosis is concerned, but the most important symptom and the sign which we don't look for, all other things which you look for, is the tachypnea. It is not just a symptom, it's a sign and a symptom. You need to count the respiratory rate for full minute, not multiply it by 4 after counting for 15 seconds, which everybody do. Why count for full minute? Because the chest rocks. If there is a fire in this room, all of you take a deep breath because you want to save yourself from hypoxia. But the child cannot take a deep breath. Its chest is not made for the depth. It is made for breathing more number of times. Therefore, as a function of hypoxia, we measure the respiratory rate, and all of you know the chest wall properties. Pediatrician is required because otherwise there will be overdiagnosis and underdiagnosis of pneumonia in the following situations. Asthma, too much of X-rays, too much of CBCs will all make overdiagnosis. Message number 5, this is the last message. How we should do the diagnosis, a clinical diagnosis, not to do under and over investigations. Treatment is all about antibiotic stewardship. This is most important slide for you, when to give azithromycin and when to give oseltamivir. I think you can take a screenshot, read later. This is the question that I get in every conference, and therefore I made a small slide of this. Severe or hospitalized, you have to give first line or second line of drugs. Staff, based on the sensitivity, you have to treat. Empirical therapy and antimicrobial stewardship, which is available in all the guidelines you follow. There is not much of update for me. Last message. What it appears in your clinic can be different from reality. You may feel that the child is doing well, suddenly you will hear that the child is in the ICU after 4 hours. Please remember this. He may appear like this, but actually the pneumonia may be like this. We will get cheated. All of us will say clinical diagnosis, clinical diagnosis. Please remember. Or on an X-ray, there may be artifact and it looks like pneumonia. Have you seen that? No, I feel like giving antibiotics. Therefore, it may appear like this, but actually it may be like this. My dear friends, you can have both sides in pneumonia, clinical versus reality. And though the clinical diagnosis is the gold standard, you need to keep your eyes open and monitor. My dear friends, every breath counts. Therefore, count every breath. I think this is a very good message from me. Let us make Black India green. This is our social responsibility. And therefore, pneumonia is not just a disease. More than a disease, is a problem for all of us. And thank you very much from both of us. And lastly, let me tell you, all of you, please message to me. I will send you the slides. Absolutely no problem. Please share and care for the children with pneumonia. Thanks for extra 2 minutes for chairpersons and for the audience for listening to this. It's very difficult to contain the entire pneumonia in 20 minutes, but I did my best, I suppose. I'll be very happy tomorrow if you count the respiratory rate, whether you treat or not. And thank you very much.
Thank you.